Hello students. Welcome to Concepts of Care for Patients with Non-Inflammatory Intestinal Conditions. This is the last part of this chapter, and we are going to talk about irritable bowel syndrome, abdominal trauma, herniation, hemorrhoids, and I think that's it. Okay. Okay, irritable bowel syndrome. Let's start with a video so we can understand much better this. Okay, video playing now.
IBS is a chronic condition affecting your large intestine. Your large intestine, also known as your colon, includes the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anal canal. The muscular wall of your colon contracts in a rhythmic fashion called peristalsis to move the intestinal contents toward your rectum. As it contracts, your colon absorbs water and nutrients from partially digested food moving through it. Waste material, called stool, is stored in the rectum until it is expelled through the anus as a bowel movement. With IBS, the muscular contractions of your colon are abnormal. In some cases, the contractions may cause food to move too quickly through your colon. As a result, your colon does not have enough time to absorb most of the water from your food. This condition leads to a watery stool and diarrhea. In other cases, the contractions may cause food to move too slowly. As a result, your colon absorbs too much water from your food. This condition leads to a hardened stool and constipation. It is unclear why your colon contracts abnormally. However, if you have IBS, your colon may be more sensitive to certain factors such as stress that seem not to affect most people. Other symptoms of IBS include abdominal pain and discomfort, bloating, gas, and cramping. You can manage your IBS symptoms through a combination of dietary habit changes, stress management, and medications. Eating food high in fiber creates softer, bulkier stools, which may prevent spastic colon contractions. Fiber also helps relieve constipation. Stress management therapies, such as hypnotherapy and yoga, may help relieve your symptoms. Your doctor may prescribe medications to help manage your symptoms, such as anti-constipation drugs to help regulate your bowel movements, antispasmodic drugs to minimize muscle spasms and reduce pain, or sedatives and antidepressants to relieve anxiety and elevate your mood.
Thank you so much. This was a great video. I am very happy with the type of video I'm presenting in our lectures. They are coming for very knowledgeable resources, professional resources, and they are really fantastic. I think that helps in our learning. So, what happened in irritable bowel syndrome is a function GI disorder that causes chronic or recurring diarrhea or constipation and of abdominal pain and bloating. It is sometimes referred to as spastic colon, mucus colon, or nervous colon. Okay, so this condition, as I told you before, the abdominal, the gastrointestinal, is the second brain in the body. So this condition is depending on stress, anxiety, right? Um, um, nutrition, of course. But that's why in the video they mentioned that the doctor will prescribe some antidepressants. Okay, we are going to explain this deeply as we move forward. Pathophysiology review. IBS is the most common digestive disorder seen in clinical practice. Okay, if you have constipation or diarrhea and abdominal pain and you go to ER, the resident is going to start asking you, and don't be surprised that he may ask you about how was your relationship, how is your relationship with your husband, your wife, um, do you have any trauma during childhood. I'm serious, this is really strongly related to emotions. Okay, so IBS causes GI motility changes. An increase or decrease bowel transit times result in changes in the normal elimination pattern to one of these classifications. So IBS could be IBS-D, which is IBS diarrhea type, or IBS-C, which is the one with constipation, or a mix of diarrhea and constipation. And that's a typical presentation happens with the students when they are going to pass the boards. So before the exam, they are having constipation, right, for a week maybe. And then after they finish the exam, then the IBS with diarrhea is going to present as the stress is over. Okay, symptoms of the disease typically begin to appear in young adulthood. Research suggests that a combination of environmental, immunologic, genetic, hormonal, and stress factors play a role in the development and course of the disorder. So environmental factors include foods and fluids such as caffeinated or carbonated beverages and dairy products. Okay, pay attention to that. Analyze your diet and try to compare it if you have irritable bowel syndrome. Maybe yes, because you are students, you are under a lot of stress, right? So if you are having constipation, you are having exam coming up, and you are drinking coffee or soda and maybe milk, then you are going to start seeing this presentation. Several studies have found that patients with IBS often has a small bowel bacterial overgrowth. Of course, because there is a delay in the emptying of this intestinal contents, right? So you don't want to have that in your in your abdomen, right? So you want to get rid of that. That's why bacterial overgrowth is going to happen, which causes bloating and abdominal distension. Also, the flora in the gastrointestinal can be affected. There is a presence of Pseudomonas aeruginosa, and these are present in water, including from sink, bathtubs, pool, hot tubs, humidifiers, and kitchen. Soil food, contaminated medical devices, pay attention, including a ventilator or urinary catheter, skin contact. Some studies suggest that up to 33% of hospital patients may encounter Pseudomonas aeruginosa. Okay, so that could happen in the hospital setting, clinical setting. Immunologic and genetic factors have also been associated with IBS, like interleukins 6 and 8 and tumor necrosis factor. At this point, you are very familiarized with these terms since I really explained this on detail in previous chapters, right? In the United States, women are 2 times more likely to have IBS than men. The difference may be result in hormonal differences. So woman, why woman? Because remember, it could happen before perimenopause, in which women are having different changes in mood, and remember this disorder is most of the time is emotional, right? Women, we go through a lot of stress. We have to take care of the family. We have to think every day what we are gonna cook. We're worried about the finances in order to put the bread on the table. We have our stress from the job, right? We need to maintain the peace in our family with our partners, with our children. So there's a lot of factors. Considerable evidence relates stress and mental or behavioral illness, especially anxiety and depression, to IBS. There you go. Many patients diagnosed with IBS meet the criteria for at least one primary mental health disorder. However, the pain and other chronic symptoms of the disease may lead to secondary mental health disorder. For example, when diarrhea is predominant, patients fear that there will be no bathroom facilities available and can become very anxious. As a result, they may not want to leave their homes or travel on trips where bathrooms are not always available. The long-term nature of dealing with a chronic disease for which there is no cure can lead to secondary depression in some patients. Let me make a parenthesis. Not only that, there are some cultures that they don't feel comfortable having a bowel movement outside of their homes. There are some patients from specific cultures that they don't want to have a bowel movement outside of the house. If they are working, they are gonna hold on that, right? They are going to stop, they are going to avoid going to the bathroom, and they are going to wait until they go back home. So all these muscles, okay, are going to start being trained in a not healthy way. Okay, so that's something you need to consider whenever you do your assessment. You need to ask. The culture is very important. It's not offensive. When you are doing assessment on the patient, you need to know the entire environment and condition of the patient. Okay, so then interprofessional collaborative patient with severe cases of IBS may need to be hospitalized due to impaired fluid and electrolyte balance. Dr. Matalana, now I'm confused. You told me that the small intestine is the one that we need to monitor for fluids and electrolyte imbalance. And this IBS is mainly happening in the colon, which the only activity the colon has is to absorb water, right? So there you go. Critical thinking, nurses, okay? If you have a intestinal content that is causing constipation, okay? Now, this content is going to be more present for a long period of time in the colon, so that is going to affect the previous section of the abdominal, of the gastrointestinal system, which is the small intestine, right? The same way, if the passage of the content is too fast to the point that the colon cannot absorb the fluid properly, that also is going to cause diarrhea. So please, okay, you have to think logically how this is affecting the entire system, okay? Okay, so assessment. Ask the patient about a history of fatigue, malaise, abdominal pain, changes in the bowel pattern, constipation, diarrhea, or an alternating pattern of both, or consistency of stools and the passage of mucus. Okay, believe me, many nurses suffer from IBS. In the moment they step into the unit, right, they don't have time to go to the bathroom for urination. They don't have time to go to the bathroom for bowel movement, that they start creating a habit. Okay, so at the moment they finish their shift, diarrhea is present. Okay, now think also, you enter, any nurse enters, starts the shift, and they give you a report for your district, right? And you need to face that this patient is post-surgery, the other patient is having mental issues, you need to take care of an elderly patient that is not following instruction, is confused, is going out of bed without any safety measures. Then you have another patient that probably is a critical condition, is going to be transferred to hospice. And all those factors, stories, are emotions that you are absorbing, right? You are absorbing that. That's why I always recommend you to have a stress management technique, okay? So you don't affect your gastrointestinal system. Okay, so patients with IBS do not usually lose weight, of course, okay, because they are having this content there. Ask whether the patient has had any GI infection or any, you need to collect also information about the drugs that the patient is taking, the nutritional history, including the use of caffeinated drinks or beverages sweetened with sorbitol or fructose, which can cause bloating and diarrhea. Okay, so when we talk about the type of stool, we need to double check what is the nature, how is the characteristics of the stool. Is it steatorrhea, melena? You need to master all these concepts. The course of the illness is specific to each patient. Most patients can identify factors that cause exacerbations, such as diet, stress, or anxiety. Food intolerance may be associated with IBS, like, for example, dairy products, those with lactose intolerance or milk protein, raw foods, and grain can contribute to bloating. Yes, if you don't have the good bacteria in your gastrointestinal system, all these foods are not going to be processed properly, right? Flatulence, excessive gas, flatus in the intestine, and abdominal distension are playing a role also. Patients may keep a food diary to record possible triggers for IBS symptoms. Okay, so then just remember there are some drugs that can cause IBS, like, for example, amitriptyline, which is an antidepressant. So pay attention to the type of drugs the patient is currently taking. Remember that the gastrointestinal is the second brain in the body. A flare-up of worsening cramps, abdominal pain, and diarrhea, and or constipation may bring the patient to the primary healthcare provider. One of the most common concerns of patients with IBS is pain in the left lower quadrant of the abdomen, although it's not always present. Okay, now the constipated stools are small and hard. We know that the diarrheal stools are soft and watery with mucus, and that's something that we need to analyze. We need to assess everything. Patients with IBS often report belching, gas, anorexia, and bloating. The patient generally appears well, and bowel sounds vary but are generally within normal range. With constipation, bowel sounds may be hypoactive, of course, and with severe diarrhea, they may be hyperactive. So big party there. Okay, routine laboratory values, including a complete blood count, serum albumin, erythrocyte sedimentation, which is your marker for inflammation, and stools for cold blood, remain normal in IBS. Some healthcare providers request the hydrogen breath test or a small bowel bacterial overgrowth health test. Okay, so we're gonna watch a video to remind you how these tests are done, even though I put this video before, but just in case you are not watching all the videos, this is a refresh. Okay, here is the video.
Hi, My name is Dr. Sharif Tolor, consultant gastroenterologist at Mediclinic Dubai Mall. I'd like to talk about the breathing tests that we are offering via our recently launched gut health clinic at Mediclinic Dubai Mall. We offer urea breath test. Urea breath test is a test to detect for a bacteria called Helicobacter pylori, which is a very common infection of the stomach. This bacteria can cause a lot of problems. It can cause gastritis, erosions, ulcerations, and in rare cases even cancer. The test is aimed to detect for the bacteria. You are asked to come in after 4 hours of fasting and given a pill, and 30 minutes later you'll be asked to blow into a balloon and we can detect the bacteria. So if you have symptoms of abdominal bloating, discomfort, pain, fullness, or any of the other symptoms, you may need this bacteria test. I'd like to now talk about HBT, or the hydrogen breath test. This test is aimed to detect for any bacterial overgrowth in the small intestine. As we know, we have millions of bacteria in our gut, especially in our intestine, and sometimes when the bacterial level gets imbalanced or the levels go high in the small intestine, you get symptoms. We aim to detect this with the breath test, which is called the hydrogen breath test. Basically, you come in after 12 hours of fasting in the morning, and you'll be given a mixture of drinks, and over the next 3 hours you'll be asked to blow into a machine, and we can detect for the bacterial excess, but also we can detect for any lactose or fructose malabsorption. So if you have excess gas, flatulence, abdominal distension, bloating, you may need this test. Thank you.
Thank you, doctor. That was very explanatory. Excellent review, even for the urea breath test. Okay, so that was called, the most important for this chapter is the hydrogen, is the second test he was talking. Inform patients that will need to be MPO and may have water for at least 12 hours before the hydrogen breath test, as the doctor explained. At the beginning of the test, the patient blows into a hydrogen analyzer for a baseline reading. Next, a dose of lactulose is ingested, and additional breath samples are taken every 20 minutes for 1 to 2 hours. Okay, interventions. What are we gonna do with this IBS? So we have to do a lot of health teaching, drug therapy, about drug therapy and stress reduction. Some patients also use complementary and integrative therapies. A holistic approach to patient care is essential for positive outcomes. Dietary fiber and bulk help produce bulky, soft stools and establish regular bowel elimination habits. The patient should ingest about 30 to 40 grams of fiber each day. So major calculation, how much is that on tablespoons? Is approximately 2.5 tablespoons. Each day, eating regular meals, drinking 8 to 10 glasses of water each day, and chewing food slowly help promote normal bowel function. So that's good to know. NCLEX alert. You need to know how to promote bowel elimination, okay? So you drink your water, you eat your fiber, and you are going to teach the patient to chew food slowly, but also you need to do your exercise, okay? The primary healthcare provider may prescribe bulk forming or antidiarrheal agents or newer drugs to control the symptoms, depending on the IBS type. Okay, so for the treatment of constipation, IBS-C, bulk forming laxatives such as Phycilium hydrophilic muciloid are generally taken at meal times with a glass of water. The hydrophilic properties of this drug help prevent dry, hard, or liquid stools. Lubiprostone, which is another treatment, is an oral laxative approved for women with IBS-C, IBS with constipation, and this drug increases fluid in the intestine to promote bowel elimination. It's all about the fluid that the bowel, the large colon, is going to absorb. So if you let the bowel absorb that fluid, and the bowel is going to make peristalsis, the intestinal content is gonna go easily through the entire ascendant, transverse, and descendant colon, okay? Teach the patient to take the drug with food and water. Linaclotide is one of the newest drugs for IBS with constipation. It works by stimulating guanylate cyclase receptor in intestines to increase fluid, and promote bowel transit time. The drug also helps relieve pain and cramping that are associated with IBS. Teach patient to take this drug once a day, about 30 minutes before breakfast. So there you go. You have your levoprostone and you have your linaclotide, and those two are they have different patient education. Okay, make notes, take notes, make sure you know this. Remember that your NCLEX, it has a high percentage of questions related to pharmacology. Diarrhea predominant, which is your IBSD, may be treated with antidiarrheal agents such as loperamide that we know, ampicillium, a bulk forming agent. Allocetrone, a selective serotonin receptor antagonist, may be used with caution in women with IBS with diarrhea because they should be used as a last resort when they have not responded to conventional therapy, right? So patients taking this drug must agree to report symptoms of colitis or constipation, okay? Because this is associated with potentially life-threatening bowel complications, including ischemic colitis. So with IBS, the type of diarrhea, this allocetrone is going to cause is going to stop the diarrhea, but may cause constipation. So be careful, NCLEX alert. Okay, now nursing safety priority. Again, they are reminding us about allocetrone interacts with many drugs in a variety of classes. Remind patients that they should not take psychoactive drugs or antihistamines while taking allocetrone. Take notes of this. Remember your pharmacology questions in NCLEX. Teach patients to report severe constipation, fever, increasing abdominal pain, because if constipation is present, probably a bacterial overgrowth is going to occur. Increasing fatigue, dark urine, bloody diarrhea, or rectal bleeding as soon as it occurs, and to stop the drug immediately. Patients with IBS who have bloating and abdominal distension without constipation have success with rifaximin, which is an antibiotic that works locally with little systemic absorption. Okay, the U.S. Food and Drug Administration originally approved this drug for travelers' diarrhea. Okay, that's another important recommendation. You can teach your patients, right, to go to the PCP and get a prescription of rifaximin, especially if they are going to travel to non-developed countries. Okay, and now has been approved for the use of IBS with diarrhea. We have somebody with a cold here at home and is sneezing. God bless you. For IBS, in which pain is the predominant symptom, tricyclic antidepressants such as amitriptyline have also been used successfully, okay? So remember, this condition is all related to emotions, okay, most of the time. If patients have postprandial after eating pain, they should take this drug 30 to 45 minutes before mealtime. So you have kind of 5 medications that you need to take notes in what moment the patient needs to take them, right? In this chapter, we don't have the classic table with the medications and patient education and side effects or how the patient needs to take the medication. So you need to take notes and elaborate your own list, okay? So complementary and integrative health in cases in which patients have increased intestinal bacterial overgrowth. Recommend daily probiotic supplements. Probiotics have been shown to be effective for reducing bacteria and successfully alleviating GI symptoms of IBS. So talk to your primary care provider. Probably he is going to suggest you a specific probiotic, maybe 10 millions formulation, 50 millions with different types of bacteria, 60 million. So first talk to your primary care in order to see what type of probiotic is the best choice for you. There is also evidence that peppermint oil capsules may be effective in reducing symptoms for patients with IBS. So peppermint oil is a blessing for many things, can help you with a headache, can help you with during your exam when you're going to pass the boards. You put some peppermint oil on your neck, in your forefront, on the clothes close to your wrist, so you smell that, because they are not going to allow you to bring the peppermint oil little bottle in the exam. So you just put there, and this is going to make you aware. You're gonna wake up. This exam is 4 or 5 hours, I don't know, so you need to be aware, okay, and awake. So peppermint oil is going to help you also to study. When you have your study sessions, put infuser, right? And essential oil infuser, and you can put peppermint oil there, and you are going to absorb the knowledge much better. So stress management is also an important part of holistic care. Relaxation techniques, meditation, and yoga may help the patient decrease GI symptoms. If the patient has a stressful work or family situation, personal counseling may be helpful. Based on patient preference, make appropriate referrals or assist in making appointments if needed. So I just want to share our website. It's from the Yoga Institute. This website is excellent. Try to subscribe. I always suggest, you can see here in this website, they have a lot of videos related to yoga, related to how to prevent hair loss naturally, yoga poses for diabetes, how you detox your intestine, increase your oxygen level. Try to get in and subscribe in this. It's very, very it's very healthy. It's a good website. Okay, they talk about all topics, okay. Now, NCLEX question. A nurse is teaching a client about best practices to promote colon health and elimination. Which recommendation would the nurse include? So you are going to mention eat low fiber foods to increase? No. Drink at least 8 to 10 glasses of water each day? Yes. Eat soft food to avoid excessive chewing? Eat soft foods to avoid excessive chewing? No. Take laxative each night to promote elimination? That's a no-no. You don't want to be dependent on laxative. So the answer is B. And here you have the whole rationale, right? That you can go over and read it while I start another topic, abdominal trauma. This is new in this edition. It's not on the 10th edition, okay? So that's why you need to buy your 11th edition. Okay, please do so as soon as possible. Trauma is an injury caused by external forces. Abdominal injuries are the third leading cause of death. Abdominal trauma typically occur in one of two ways, blunt or penetrating. Okay, that's good. The severity, that's good to know. The severity of abdominal trauma varies depending on the force, nature, and mechanism of injury. Blunt and penetrating trauma may cause hematomas, and at this point you should be able to describe what is an hematoma. lacerations or ruptures of abdominal organs and structures. I've seen some nursing students describing ecchymosis and as an hematoma. Okay, you need to master your terminology. If untreated, these injuries put the patient at risk for severe complications, including intra-abdominal hemorrhage, infection, we know peritonitis or abscess, paralytic ileus that we know right now that is the lack of peristalsis. Abdominal compartment syndrome may happen, hypovolemic shock, and bowel obstruction. So hemorrhage, which leads to hypovolemic shock, and hollow viscous perforation, which leads to septic shock. We need to pay close attention to those life-threatening conditions. Hemorrhage frequently occurs when the liver or spleen is damaged. We are talking about abdominal trauma. Okay, so again, hemorrhage frequently occurs when the liver or spleen is damaged. Based on diagnostic testing, these injuries are graded from 1 to 5, which is the worst, based on the extent of the injury, including the percentage of organ that is injured. Hollow viscous injuries cause perforation of the stomach, small intestine, and or colon, gastrointestinal contents leaking to the peritoneal cavity, causing peritonitis and sepsis. And I would say death if the team is not moving fast with all the surgeries and stuff they need to do. Abdominal compartment syndrome is a serious complication of abdominal trauma that causes end organ dysfunction caused by intra-abdominal hypertension. It arises when damage to the abdomen causes capillaries in the intestine and mesentery. And at this point, we know the difference between peritoneum and mesentery, right? The mesentery is the wall in the back of the abdominal cavity, which holds the organs to which holds the organ to be placed in their position by holding the organs in the back wall, in the posterior wall of the abdomen, right? The peritoneum is the back that covers all the organs. Okay, that's the difference. Okay, so it arises when damage to the abdomen causes capillaries in the intestine and mesentery to become leaky, producing edema in the tissues of the abdomen. The edema causes increased abdominal pressure, pain, organ compression, and ischemia. Surgical intervention is often necessary to decompress organs and prevent organ damage and failure. Okay, so now you understand the entire presentation. Emergency department and hospital setting is going to be basically the place where the patient is going to present for this abdominal trauma. The assessment before specifically assessing the patient with abdominal injury, complete the primary survey and any resuscitation interventions, right? After the interprofessional team addresses immediate life-threatening issues, ask the patient to relay the story of the mechanism of injury if possible. Remember, this patient is presenting to the ER with an abdominal injury, abdominal trauma, so probably is going to be very sick, right? So probably there is no room for assessment, questions, and the full interview. Okay, so assessment findings in patient with blunt abdominal trauma. This part is extremely important, especially for those of you who wants to work in the ER. you are going to see purplish or darker areas in flank areas or umbilicus. That is known as Cullen sign. I want you please to pay attention and memorize these signs, because we are going to talk about these signs when we talk about pancreatitis, okay? All the disorders related to the pancreas. So Cullen sign, which may indicate blood in the abdominal wall. We're going to watch a video so we understand. Dr. Matalana, I don't understand what is Cullen sign. Okay, let me play a video. Here it is, very short video.
Cullen sign is often seen in severe pancreatitis, and it's characterized by periumbilical bruising and edema, and is caused by retroperitoneal bleeding.
Okay.
Cullen sign is often seen in...
So you see, that's Cullen sign right there. Now, ecchymosis or darkened areas in flank area. That's Turner sign, which may indicate retroperitoneal bleeding or pancreatic injuries. So now we're gonna watch another video. So Cullen is going to be in the abdomen, right? And Turner sign is going to be...
Grey Turner sign might be seen in severe pancreatitis and is characterized by flank bruising, and the cause of it is retroperitoneal hemorrhage that's tracked to the flank.
Okay, so that's going to be on the flank, okay? That's Turner. Now, hematoma in flank area also is another presentation which may indicate kidney injury. And then we have another one on the left shoulder called, but before that, I want you to make a parenthesis, because I love to explain stuff, and I want you to be very specific on the difference between Cullen and Grey Turner. So Cullen is caused by bleeding with or behind the peritoneum, okay? The serous membrane lining the cavity of the abdomen and covering the abdominal organs. We know that. A variety of conditions may result in hemorrhage within the abdomen. The most common cause is acute pancreatitis. Okay, that's why I told you, remember this Cullen sign. But also it could be caused by this abdominal trauma. This acute pancreatitis can cause Cullen and Grey Turner signs. Now, Grey Turner describes the discoloration and ecchymosis of the bilateral flanks. So the ones on the side are Grey Turner, and Cullen is going to be specifically behind the peritoneum, right? So now we talk about the Kern sign, which may indicate ruptured spleen or diaphragm irritation or damage. So let me play the video about Kern sign. Okay, let me play the video. Okay, here we go. Remember all of this.
Kehr's sign is the occurrence of acute pain in the tip of the shoulder due to the presence of blood or other irritants in the peritoneal cavity when a person is lying down and the legs are elevated. Kehr's sign in the left shoulder is considered a classic symptom of a ruptured spleen. Also, the smaller branches of splenic artery which supply the spleen are end arteries. Their obstruction results in splenic infarction, which causes referred pain in the left shoulder.
Thank you so much. So why the left shoulder? Because if Kern sign is manifesting on the left side, means that the spleen is affected. Spleen is on the left side, right? It's on the upper left quadrant, spleen, okay? So that's why the Kern sign is going to be referred to the left shoulder. Now, abdominal distension also is another presentation which may indicate bleeding, ascites, or peritonitis from leakage of GI content. So there you go. You have 3 signs that you just learned. Remember them for the pancreatitis section. Perform an abdominal assessment, keeping in mind that a specially trained practitioner, surgeon, or emergency care provider should perform any significant palpation and percussion. You are not supposed, nurses, to do this assessment. Let the resident, the doctor, the surgeon do this, okay? Because you can cause more damage in the area. Inspect the abdomen for abrasions, discoloration, or distension. However, you need to master by inspecting, right? Oh, I see bruises in the abdomen. That could be a Cullen sign. Oh, I see bruises on the flank of the patient. That could be a Turner, right? So bowel signs may be decreased or absent due to bleeding, organ injury, peritonitis, or paralytic ileus. Monitor nausea and vomiting with or without blood. The symptoms may indicate organ damage or obstruction. Vital signs should be completed to monitor for hemorrhage, shock, sepsis. Also assess for pain, the region, and you can use your old cards mnemonic here, where, the location, the duration. Worsening pain can be indication of continued bleeding, perforation, or abdominal compartment syndrome, which will require immediate medical attention. During the primary survey in the ER, the patient with abdominal trauma usually has a bedside focus assessment with sonography for trauma. They are going to bring they are going to make the sonogram at the bedside. After the patient receives resuscitative care, an abdominal computer tomography scan is typically performed to better visualize fluid, blood, or structural damage. So now the interventions, management of abdominal trauma varies based on the severity and the presentation, right? So no non-surgical management. Patients who do not require immediate cervical intervention are carefully monitored in the intensive care unit. The assessment includes vital signs, pain, laboratory assessment. They are going to check your hemoglobin, hematocrit to check for bleeding. If needed, they are going to administer blood transfusion. Wound care is going to be provided. Oxygen therapy or mechanical ventilation is going to be started in case of, depending on the clinical presentation. Hollow viscous injuries receive antibiotic therapy to prevent sepsis from peritonitis. And remember, the hollow viscous injuries is injury in the stomach. Surgical management, the laparotomy, which is completed by making an incision into the abdominal cavity. This procedure allows visualization of the abdominal organs of the abdomen and repair of any injuries, which is really necessary, right? Because this is an abdominal trauma presentation. Especially they are going to do exploratory laparotomy after the ED team's primary survey due to significant hemorrhage or decompensation. An exploratory laparotomy may also be performed if the patient shows signs of decompensation while under observation in ICU. Maybe there is a hidden perforation somewhere. Postoperative care, monitor in the ICU for bleeding, infection, and as I explained before, hollow viscous injuries are going to receive antibiotic. Now let's switch to herniation. Okay, this is our third topic. So we cover irritable bowel syndrome, abdominal trauma. Let's talk about herniation. A hernia is a weakness in the abdominal muscle wall through which a segment of the bowel or other abdominal structure protrudes. Hernias can also penetrate through another defect in the abdominal wall, through the diaphragm, or through other structures in the abdominal cavity. Pathophysiology. Two elements of hernia formation include congenital or acquired muscle weakness. So in the moment a patient is presenting with hernia, you need to ask yourself, is it congenital or acquired? So we have to consider congenital or acquired muscle weakness and increased intra-abdominal pressure. The most significant factors contributing to increased intra-abdominal pressure are obesity, pregnancy, and lifting heavy objects. So that's why your assessment must be thorough. Okay, and that's good to know. So an indirect inguinal hernia is a sac formed from the peritoneum that contains a portion of the intestine or omentum. The hernia pushes downward at an angle into the inguinal canal, right? In males, indirect inguinal hernias can become large and often descend into the scrotum. So then we have a second type, direct inguinal hernias, in contrast, pass through a weak point in the abdominal wall. Direct inguinal hernias. Third type, femoral hernias protrude through the femoral ring. Fourth type, umbilical hernias are congenital or acquired. Congenital umbilical hernias appear in infancy, and acquired directly result from increased intra-abdominal pressure. They are most common in people who are obese. And now, incisional or ventral hernias occur at the site of a previous surgical incision. So I want you to understand that a reducible hernia is one in which the content of the hernial sac can be placed back into the abdominal cavity by application of gentle pressure. And you are not performing that maneuver, okay? Please. It's just for your general knowledge. An irreducible incarcerated hernia cannot be reduced or placed back into the abdominal cavity. Any hernia that is not reducible requires immediate surgical evaluation. Now let's talk about strangulated hernias, and I'm going to play a video because I want you to focus on this one. This one is the worst scenario, okay?
This brief video examines the dangerous complication associated with hernias, which is strangulation, by way of a simple line drawing. So let's look at this drawing over here. On this side are the loops of bowel. This is the abdominal wall in its cut section, and you can clearly see a defect in the abdominal wall allowing a loop of bowel to traverse that and then come back inside. This is the skin, and this is the subcutaneous tissue, which is generally fat. So let's see, why does strangulation happen and what does it mean? Strangulation simply means that the blood supply to an area has been cut off. And how does it happen? How does it happen? Typically, bowel travels into the hernial sac through the neck, which is the most dangerous part, i.e. that is the narrowest part through which the bowel has traversed into the sac. And if it tightens, it will cut off the blood supply, and the trapped bowel will be dead and become necrotic. That is a life-threatening complication. Now, moving on to the symptoms, typically patients feel pain, but this time this pain is quite different to the kind of dragging pain that they may be used to. So the hernia becomes very painful, it may get bigger in size, and it may be accompanied by other abdominal symptoms such as generalized abdominal pain, vomiting, and nausea. Now, if there is bowel perforation, then the abdominal symptoms could be a lot worse, and patients may have constitutional symptoms such as low blood pressure and a high pulse rate. Now, hernias become irreducible. What does that mean? For most patients, hernias can go in and out, so when they are lying down in bed at night, the hernia disappear back inside and the area looks quite flat. When strangulation happens, then the bowel or the contents are trapped and no longer travel back inside. And in late cases, the skin overlying the hernia may become quite red and inflamed. So if these symptoms arise, please seek early medical help by going to the nearest hospital. The patient would require urgent surgery to rid them of this dreaded complication.
Thank you very much, doctor. So this is the one I want you to focus because there is a specific care for this strangulated hernia, okay? So if the hernia is strangulated, ischemia and obstruction occur in the bowel loop. This can lead to necrosis of the bowel, sepsis, and possible bowel perforation. Signs of strangulation are abdominal distension, nausea, vomiting, pain, fever, and tachycardia, because fever always comes with tachycardia. Indirect inguinal hernias are the most common type, occur mostly in men because they follow the tract that develops when the testes descend into the scrotum before birth. Direct hernias occur more often in older adults. Femoral and adult umbilical hernias are most common in pregnant women, and those with obesity. Incisional hernias can occur in people who have undergone abdominal surgery. So the collaborative care, patients with inguinal hernias often need surgery in a same-day surgical facility. So assessment, the patient reports a lump or protrusion felt at the involved site associated with straining or lifting. Perform an abdominal assessment, inspecting the abdomen when the patient is lying and again when the patient is standing. Well, that's very important. So you need to do two assessments when the patient is lying, okay, because you can see the protrusion, and when the patient is standing, it's going to allow you to see where the hernia is, what pathway is following, okay? If the hernia is reducible, it may disappear when the patient is lying flat. Provides the healthcare provider is going to instruct the patient to strain or perform the Valsalva maneuver, and we know what is that, right? And observe for bulging. Auscultate for active bowel sounds. Absent bowel sounds, again, may indicate obstruction and strangulation, which are considered medical emergencies. So always absent bowel sounds are dangerous. To palpate an inguinal hernia, the PCP gently examines the ring and its content by inserting a finger in the ring and noting any changes when the patient coughs. So coughing is a good way to assess for hernias. The hernia is never forcible reduced. This maneuver could cause a strangulated intestine to rupture. So let me play a video. You are going to understand how the hernia is visible when the patient is coughing. Look at that. Okay, so that was the coughing and the visibility of the hernia, right? Now, using the right hand, there is another way to assess for the hernia. The hernia in the groin. So if a male patient suspects a hernia in his groin, the PCP has him stand up for the examination and using the right hand for the patient's right side and the left hand for the patient's left side. The examiner pushes in the loose scrotal skin with the index finger following the spermatic cord upward to the external inguinal cord. At this point, the patient is asked to cough and any palpable herniation is noted. And this is basically a skill that is performed by the PCP or the nurse practitioner or PAs. Okay, so now what are going to be the interventions for non-surgical management? Patients who are not a candidate for surgery, those with multiple health problems may utilize a truss for an inguinal hernia. So what is a truss, Dr. Matalana? Let me play the video for better understanding. Okay, I got you. Okay.
Braceability, inguinal hernia belt. Use post or pre-surgery to provide constant, comfortable, and adjustable pressure to your hernia. Unlike any other support on the market, use interchangeably to treat single or double hernias. Adjustable tension straps allow you to position the anatomically shaped compression pads directly over your hernia. Breathable, machine washable, skin-friendly material. Fits men and women.
Okay, so basically that's the idea, right? Besides the marketing of the brand, that's the idea. So a truss is only after the primary care provider has reduced the hernia and it is not incarcerated, right? The patient usually applies the truss on awakening and teach the patient to assess the skin under the truss daily and to protect it with a light layer of powder. Okay, moving forward, surgical management. Most hernias are inguinal and surgical repair is the treatment of choice. So when bowel strangulation and tissue death occur, more extensive surgery such as bowel resection or temporary colostomy may be necessary. Other surgical repair of an hernia is called herniorrhaphy. Okay, a minimal invasive inguinal hernia repair is done through a laparoscope. Okay, that's another type. A conventional open herniorrhaphy may be performed when laparoscopy is unsuitable. So you have the two approaches, right? Either via laparoscope, which is always be more beneficial, fast healing, less hospital stay, right? The most important preoperative preparation is to teach the patient to remain MPO for a number of hours before surgery, right? And during the minimal invasive inguinal hernia repair, the surgeon makes several small incisions. We know this is the laparoscopic style. When a hernioplasty is also performed, the surgeon reinforces the weakened outside abdominal muscle wall with a mesh patch. That's important concept to understand as well, because by understanding that concept, you're going to provide better nursing care. Teach the patient to avoid strenuous activities for several days before returning to work and a normal routine. A stool softener may be needed to prevent constipation. Caution patients who are taking oral opiates for pain management: do not drive or operate heavy machinery. Teach them to observe incisions for redness, hyperpigmentation, swelling, heat. This is all related to assess for infection. Remind patients that soreness and discomfort rather than severe acute pain are common after this minimal invasive procedure. General postoperative care of patients who undergone an hernia repair. With this patient should avoid coughing, of course, right? To promote lung expansion, we have to do whatever we do after post-surgery. We have to encourage deep breathing and ambulation. With a repair of an indirect inguinal hernia, the PCP may suggest a scrotal support and nice chips, and this is good to know. NCLEX alert. Ice bags, sorry, it's not ice chips. Ice bags applied to the scrotum to prevent swelling, which often contributes to pain. Elevation of the scrotum with a soft pillow helps prevent and control swelling. So you provide this care in a hospital, and then when the patient transitions to home, he needs to be aware of this. Male patients may have trouble voiding during the early postoperative period. Encourage them to stand for a more natural position. That's good to know. Also, patient education, allowing gravity to facilitate voiding and bladder empty. Urine output of less than 30 ml should be reported to the surgeon. And this is common sense. We know that, right? Techniques to stimulate voiding, such as allowing water to run, may also be used. Fluid intake of at least 15 to 2500 ml daily prevents dehydration, maintains urinary function, which is extremely important, and minimizes constipation, which is extremely important as well. A straight or intermittent in and out catheterization is required if the patient cannot void. So we are going to monitor for fever, we are going to monitor for wound drainage, redness, hyperpigmentation, or separation of the incision, or an increase in incisional pain. Teach the patient to keep the wound dry and clean, and cleanser and water. Showering is usually permitted within a few days. So for this patient care, I'm gonna move down. I'm gonna scroll down to this box here. I don't know why they put the box there. It should be placed under the topic, not inside of another topic. So care of the postoperative patient having a minimal invasive inguinal hernia. Monitor vital signs, assess the incision for infection. But here comes the ones in the green. I consider the ones more important, right? So you encourage deep breathing, incentivize spirometer, encourage ambulation, apply ice packs, help the patient to void by standing. So you are teaching the patient all these recommendations. Do not lift more than 10 pounds until allowed by the surgeon. Avoid constipation. And then you can analyze in more detail other factors. Now let's talk about hemorrhoids. Yeah, we are ending the chapters. Hemorrhoids are unnaturally swollen or distended veins in the anorectal region. The veins involved in the development of hemorrhoids are part of the normal structure of the anal region. So what is the pathophysiology? Hemorrhoids increase due to intra-abdominal pressure causes, and the distended veins eventually separate from the smooth muscle surrounding them, and this results in prolapse of the hemorrhoidal vessels. So hemorrhoids can be internal or external, and we are going to see an image later. Internal hemorrhoids, which cannot be seen on inspection of the perineal area, are above the anal sphincter. External hemorrhoids lie below the anal sphincter and can be seen on inspection of the anal region. Prolapsed hemorrhoids can become thrombosed or inflamed, or they can bleed. Okay, pay attention to that. Hemorrhoids are common and insignificant unless they cause prolonged pain or bleeding. And because of the increase in abdominal pressure, the condition worsens during pregnancy or with constipation with straining. And obesity, heart failure, prolonged sitting or standing, and strenuous activity and weightlifting. Decreased fluid intake can also cause hemorrhoids because of the development of hard stool and subsequent constipation. Straining while evacuating stool causes hemorrhoids to enlarge. So right there in this explanation is they are presenting you the description, the presentation, but also you understand what you need to do in order to prevent hemorrhoids, right? So health prevention. Constipation can be prevented by eating more whole grains, raw vegetables, fruits to increase fiber in the diet. Please remember, we are talking about raw vegetables, okay? not cooked. Encourage patient to drink plenty of water. We know that. Remind the patient to avoid straining at a stool. So in order to avoid straining, we need to have a nice bowel movement, soft. So plenty of water, fiber. Encourage regular exercise with a gradual build-up in intensity. Maintaining a healthy weight also helps prevent hemorrhoids. So that's good to know. NCLEX alert. Here in the image we can see the internal hemorrhoids, we can see the external, and we can see the prolapse. Okay, this is a very nice graphic actually. I didn't have to look for a video. Collaborative care. The most common symptoms of hemorrhoids are bleeding, swelling, and prolapse, bulging. Blood is characteristically bright red and is present on toilet, tissue, or straight in the stool. Okay, so you need to assess everything. That was nursing is all about. Pain is a common symptom and is often associated with thrombosis, especially if thrombosis occurs suddenly. Other symptoms include itching and mucus discharge. Now, cold packs applied to the anorectal region for a few minutes at a time, beginning with the onset of pain, and tepid sitz baths, which I am really fan of. This is a great therapy. 3 or 4 times per day are often enough to relieve discomfort, even if the hemorrhoids are thrombosed. That's good to know. Topical anesthetics such as lidocaine are useful for severe pain. Novocaine ointment and similar products are available over the counter and may be applied for mild to moderate pain and itching. But the most important here is to prevent this. Okay, this is preventable. So prevent by having a nice intake of fluids, raw fruit and vegetables, practicing your exercises, right? What else? When itching or inflammation is present, the primary healthcare provider may prescribe steroid preparations such as hydrocortisone. Cleansing the anal area with moistening cleansing tissues rather than standard toilet tissue helps avoid irritation. Yes, it's very important to clean the area with moistening cleaning tissues. Diets high in fiber and fluids are recommended to promote regular bowel movement. Stool softeners such as docusate sodium or Colace can be used temporarily. Irritating laxatives should be avoided. Remind patients to avoid sitting for long periods. That's good to know as well. Also, if symptoms continue or recur frequently, the patient may require surgical intervention. The surgeon can perform several procedures in an ambulatory care setting to remove symptomatic hemorrhoids. So the type of surgery could be via ultrasound or laser removal, depends on the degree of the prolapse and the thrombosis, right? So depends on the presentation. Complication of these procedures includes pain, thrombosis of other hemorrhoids, infection, bleeding, and abscesses formation. Okay, you have to teach the patient with hemorrhoids about the need to eat high fiber again, the fruits, the vegetables, to have a good bowel movement pattern after surgery. Advise them to avoid stimulant laxative, which can be habit forming. Okay, this is the most important part right here. After the surgery, right, the first operative bowel movement is going to be very, very, very painful. Okay, so be sure that someone is with or near the patient when this happens. Why? Because some patients become lightheaded and diaphoretic and may have syncope. Yes, the patient post hernia surgery can have a syncope during the first postoperative bowel movement. And this is temporary loss of consciousness related to the vasovagal response. So the primary healthcare provider usually is going to prescribe a stool softener such as docusate sodium to begin before the surgery and continue after surgery. Also, analgesics and anti-inflammatory drugs are prescribed, and these are necessary. If you don't see that in the doctor's order post-procedure, you need to request that, because that first bowel movement is going to be very painful. A mild laxative should be taken if the patient has not had a bowel movement by the third post-operative day. Okay, so safety, that's good to know. NCLEX alert. Let me move towards the mastery question. The nurse is caring for an older adult who is admitted with a diagnosis of complete large bowel obstruction. Remember, we are doing the mastery questions for the entire chapter, right? In this case, is large bowel obstruction. What would the nurse anticipate as the likely cause of the obstruction? So it's not going to be bowel volvulus. It's not going to be bowel intussusception, bowel polyp. It's going to be fecal impaction. And here is the answer with the rationale. Then we have question number 2. The nurse is caring for a client who has a nasogastric tube connected to the low continuous suction for a paralytic ileus. Okay. Which of the following nursing interventions would be implemented when caring for this client? So in this case, you see there are many because it's a selector that apply. I forgot to read that. So A, provide frequent mouth and nurse care. Yes, it's an NG tube. B, irrigate the NG tube as needed to keep patency, right? To keep patent. C, listen for the presence of vowel sounds every 4 to 8 hours. Yes. D, measure NG tube output and document. That's good. It's part of the nursing interventions. Limit the client intake to full fluids. It's not possible. F, monitor for skin integrity where the tube is inserted. Yes, that's another correct answer. Now, number 3, the nurse is planning care for a client recently diagnosed with a non-reducible inguinal hernia. So which primary healthcare provider order would the nurse anticipate? Insert a nasogastric tube? No. Prepare the client for probable surgery? That's the answer, because it's a non-reducible, right? So the answer is letter B. Administer supplemental oxygen therapy? No. No now, because probably that's going to be done during surgery. Okay. Monitor vital signs every 1 to 2 hours? No. So the answer was prepare the patient for probable surgery. Okay. With this, we have finished this chapter related to concepts of care for non-inflammatory intestinal condition. We have discussed intestinal obstruction. We have discussed colorectal cancer. We went over irritable bowel syndrome, abdominal trauma, hernias, hemorrhoids. Okay, so what else? I think I described everything. So this is the complete chapter. Thank you so much for your attention, and we will move forward with more concepts. Thank you so much.